We start with hepatitis C. Hepatitis C virus is a global public health crisis affecting 58 million people worldwide and 1 million new infections every year. Although WHO has called for global elimination of the disease, disproportionately high burden of the disease still remains in low and middle income countries. Given the silent nature of the chronic infection, countries still struggle to set up a national program in case finding and also to make a realistic estimation of actual burden of cases in the community. Hepatitis C is treatable, but access remains for very few. Given this backdrop, MSF has been working in several hepatitis C projects in different contexts. One such project is worth mentionable is the one in Bangladesh, in the Rohingya camp that is the largest refugee camp in the world. The next presentation is going to give an idea to the audience how MSF, faced by large volume of patients in the facilities, started a hepatitis C treatment project, and at the same time, listening to the demand from the community, wanted to have the knowledge of actual burden of active cases, which in the long term will inform operational decisions and advocacy efforts. To present this study, we call Birgit Schramm. She joined Epicenter as epidemiologist in 2008. She has a background in molecular virology and in control of infectious diseases. Her past years was operational research in various MSF settings, including studies on HIV, drug-resistant tuberculosis, malaria, hepatitis C, diagnostics and test evaluations. Welcome.
Thank you, Farah. Good morning, everyone. Yeah, as indicated, we are presenting today the findings of the hepatitis C prevalence survey that was conducted in Rohingya refugee camps in Cox's Bazar, Bangladesh. Of course, I don't know how that works. Yes. So a quick revisit of hepatitis C infection. It's an inflammation of the liver caused by hepatitis C virus, which is blood-borne. The main transmission routes are via blood, primarily through unsafe injections or unsafe healthcare practices. While approximately 30% of infections are cleared spontaneously within a few months, the majority will become chronic. And the risk of chronic infection is often underestimated. So in fact, if left untreated, 15 to 30% of chronic infections will lead to severe liver disease. The 2022 WHO estimate was 242,000 hepatitis C-related deaths globally, mostly due to cirrhosis and liver cancer. So early diagnosis and treatment are crucial, and as Farah indicated, we have effective treatments available. Direct-acting antivirals, DAAs, with high cure rates, however, limited access to diagnosis and treatment still globally. As Farah indicated, our setting is the world's largest refugee camp in Cox's Bazar, Bangladesh, hosting to date nearly 1 million Rohingya originating from Myanmar, residing in densely crowded camps in Cox's Bazar. These camps were established in late 2017, following a massive assault of Myanmar authorities in Rakhine State, leading to an exodus of more than 700,000 Rohingyas to Bangladesh. There's 3 MSF sections present in the camps. OCP, among other, provides the following services: inpatient care for adults in the only secondary healthcare structure available in the camps, and within 2 PHCs, besides general OPD services, mental health, NCD, and since more recently, hepatitis C care. It was noticed since the beginning that many patients seen by MSF showed symptoms of liver inflammation and decompensation, and many tested hepatitis C antibody positive. With effective treatments available and viral hepatitis on the global agenda, MSF decided to start simplified public health model for treatment of hepatitis C in the camps, adopting a model that was already deployed in Cambodia years before. The simplified case management was based on limited laboratory assessments and fewer obligatory clinical visits, and achieved high cure rates, and the capacity was set at 150 treatment initiations per month. Since the start, it was clear that the demand for hepatitis C care was high in the camps, so at times people were literally queuing up to access services. So there was an urgent need to better understand the actual burden of hepatitis C infection and generate a robust estimate of the number of people requiring diagnosis and treatment. To respond to this need, we conducted a cross-sectional survey targeting adult Rohingya residing in 7 of the 21 camps. Through simple random geospatial sampling, we targeted 680 households and included 1 adult per household randomly selected into the survey. To assess hepatitis C seropositivity, presence of antibody, we conducted a rapid antibody test on the spot. And since antibodies are for life, we need to understand among them who are actively infected, and this was done with an expert hepatitis C viral load test looking for hepatitis C RNA. We also administered a participant questionnaire to explore factors associated with exposure to hepatitis C. The main objective was to assess the prevalence of active infection in the refugee population, and among other, we also looked at the proportion of those undiagnosed and aimed to identify factors associated with hepatitis C exposure. Between May and June last year, we included 641 participants with a median age of 34 years, 66% female, and almost all had arrived during the main influx to the camps in late 2017. I'm showing you here as a first result the estimated hepatitis C seroprevalence antibody carriage, which was a striking 29.7%, 32.8% among female, and 22.1% among male, a significantly higher estimate for female. And you can see that all age groups were affected by hepatitis C exposure, with an increasing trend with older age groups, which was more pronounced among female. Next, I'm showing you here the main measure of interest, the estimated prevalence of active hepatitis C infection, which amounted to 19.6% overall, with 21% among female and 15.8% among male. Here, the difference was not significant. In terms of age groups, the lowest adult age group was the least affected, and the highest active prevalence estimates were achieved for older age group female. Another indicator of interest is the viremic ratio, which is the percent of active infection among seropositive, which was very high in this setting, 66.6%, which is kind of reflecting natural infection, with 30% of the infections clear spontaneously in the absence of treatment. So this indicated a significant gap in hepatitis C treatment coverage in the camp population. This also corresponded to the reports of hepatitis C seropositive participants, where only 38% reported previous diagnosis, and 10% reported previous treatment. We also identified a significant knowledge gap on hepatitis C infection in this setting that was highly affected. So nearly half of participants never heard of hepatitis C before. 65% didn't know that hepatitis C infection can be prevented, and 58% did not know that treatment was available. Among those who had heard about hepatitis C before, a good proportion could identify the main transmission modes, depicted in green. Among this, blood and sharing of razors or sharing of needles and syringes. At the same time, a large proportion also chose transmission modes that are not accurate, shown in red, such as respiratory droplets or food. So this underlines the lack of knowledge for hepatitis C in the camp population. In terms of factors associated with hepatitis C exposure, multivariate regression analysis identified female sex, age groups 25 years and older, reported medical injections, and reported surgical interventions significantly associated with exposure. It should be noticed that many reported having had medical injections in the past, while as only few reported surgery, to put in context the risk factors. So in summary, nearly 1/3 of adults was found exposed to hepatitis C infection. We are looking at a generalized epidemic in this camp population with about 1 in 5 adults living with active infection. And if we extrapolate our survey estimate to the general overall population in the 21 camps, we can estimate that about 86,000 adults are living with active infection requiring treatment. We also found an indication of very low treatment coverage in the camp population and very limited awareness on hepatitis C infection in this heavily affected population. I'm handing to Farah.
I hope you're listening. Because with this summary, we want to take a short pause and actually go back to you, the audience, and ask a question. Given this summary, in this scenario, what would you recommend for MSF as actions to take? Short pause. We will take one recommendation at least. Nobody? Are you afraid? Yes. I planted this person.
So a test and treat campaign, huge, big test and treat campaign with MSF and other actors as quick as possible.
Thank you, Claire. Well, we have it. So, how does it work? So, of course, we have to listen to our medical director. Our recommendations, what we call for are, of course, a mass HCV test and treat campaign for the whole camp, for which we need a rapid scale-up of access to test and treatment for the population. But we should not forget to break the transmission chain. We have to also implement a large-scale prevention and health promotion campaign. But this does not come without challenges. We cannot forget this is a highly stigmatized population. Even to disseminate the study results among the stakeholders, the mission actually had to do a lot of risk analysis. We did not want the data to be politicized against already marginalized population. And with the decreasing interest of the donors for the community, many health issues already remain, which competes with this interest. But we should not forget the cost. A whopping 8.6 million euros are needed for just the test and the treatment if we wanted to do a campaign. Of course, we don't even talk about the HR, but that will be also a huge cost because it should be in a short span of time. But the cost, of course, is not negligible. But if we do not address the situation, as Birgit was saying before, many of the cases will have severe illness, which will strain in time the already overburdened health system in the camp. Way forward, MSF should not be alone in this. This is why we are calling for a multi-partner initiative in the camp. Discussions are currently ongoing. The study results did inspire a lot of actors, so we want to see how it goes. For that, the adoption of MSF's simplified public health model is absolutely necessary because it is a big campaign and it needs to be rapidly done, and that's necessary. And for the long run, we would like integration of hepatitis C in all health centers, the treatment, so that prevention of new cases by breaking the transmission chain happens. We also want to put focused advocacy efforts. We would like to be part of Access Campaign's initiative Time for 5 and call for decrease of also hepatitis C viral load cartridges from 15 euros to 5 euros. And we would like that generic DAA importation is possible for all actors inside the camp for the campaign and in future. That's it from us. Thank you.
Bonjour à toutes et à tous.
Good morning.
Juste commencer par quelques
I
mots
would like to start with a few words
les doses fractionnées de
to tell you about this study on the fractional
c'est plus large.
dose, to put this back into a broader context, especially the fact that this, between 2015 and 2015, was one of the big cases that we looked at in access to essential medicines, and the climax of this work was a public campaign that was led towards the two labs which had a monopoly and that would sell their vaccines at the highest possible price. And the objective of that campaign was to ask those pharmaceutical firms to decrease the prices for MSF and for Gavi also. Gavi is the unit funding vaccines for the poorest countries and also for middle-income countries who do not receive funds from Gavi. And this campaign led to the obtention of a special prize for humanitarian organizations like MSF. Unfortunately, our request for middle-income countries was not met. And in the meantime, there was a new vaccine that came on the market, the third pre-qualified vaccine. It's a vaccine that I'm going to show you the study about. It was designed initially to meet the needs of low and middle-income countries, and it's a vaccine that is more than 5 times cheaper than the Pfizer vaccine. But even at $2 per dose, it's still one of the most expensive vaccines when you look at the portfolio of a vaccination program. If you look at pentavalent or the vaccine against measles, it's still one of the most expensive ones. Then you have even more expensive ones that are going to come on the market or which are already on the market, such as the malaria vaccine, for example. So, in that context, you have to understand that this vaccine is still expensive, therefore it still has a major impact on a country's budget. And this study that we are going to tell you about is really in the line of all these questions of access to vaccines, to PCVs, and we hope that the stakeholders such as WHO and the Ministry of Health or other organizations like MSF, for example, who are directly involved in vaccination, will be able to start the discussion in contexts which are difficult to access and where we don't have enough PCV vaccines in a given place. And so we would consider the use of fractional dose in order to be able to bring the vaccination to as many children as possible. And to present this study, we have Isaka Sumana. He's a doctor, a medical doctor with a training in public health and global health from the University of Louvain. Right now he's the deputy head of the Epicentre Research Center in Maradi, and he has worked on several vaccine trial projects, major ones. There was one by Epicentre in Niger, phase 3, with the rotavirus vaccine. Still from that same company that produces Pneumozil. There was also a trial in DRC for Ebola, and he is going to present this study on Pneumozil today. He also took part in field studies on anti-malarial drugs and treatments for Ebola. Isaka, your turn.
Bonjour tout le monde.
Good morning, everyone. It's my pleasure to present the results of this PCV study. It's a three-arm randomized study aiming at identifying the effect of mass vaccination campaigns using a fractional dose of anti-pneumococcal vaccine to accelerate herd protection for pneumococci in sub-Saharan Africa.
Alors, pour commencer,
Now, we know that vaccination campaigns targeting children up to 5 years of age reduce vaccine type carriage and invasive pneumococcal disease. In a context of humanitarian crisis or a high prevalence of malnutrition or low vaccination coverage,
on peut s'attendre à des taux de portage
we can expect
qui peuvent
VT carriage to be very high and extended to greater age groups. So even a strategy that used the cheapest vaccine might be very costly to implement and hard to sustain in time and would be restricted to urgent needs. So the fractional dose approach can be a good alternative. Now, for the needs of this study, we used Pneumozil, as Alain said, which is right now, it's a PCV-10, and it's the cheapest PCV, the most affordable WHO pre-qualified PCV right now. Now, about the background in Niger, it's a sub-Saharan Africa, which has introduced a PCV-13, that's the one from Pfizer, in their vaccination program in 2014. And the schedule was 3 doses starting at 6 weeks of age and then every 4 weeks. There is no catch-up campaign. And when we looked at the Maradi area, we looked at the estimated vaccine coverage in 2019, it was estimated to be at 48%. And just also, the price of this vaccine is $3 per dose, which is paid for by Gavi right now for this country. And for this study, the objective was to evaluate the superiority of a full-dose campaign targeting 1 to 9-year-olds at VT carriage reduction 6 months post-campaign compared to control. And then to evaluate if one fractional dose, one-fifth fractional dose campaign was actually had a non-inferior impact than the full dose. We used 1/5 of the dose because of previous immunogenicity data that we had, and also for logistics and practical reasons.
Pour ce faire, nous avons randomisé.
We randomized 63 clusters in a 3:1 ratio with 27 clusters in the full dose arm, 27 in the fractional dose, and 9 in the control arm.
Les grappes sont constituées d'un village ou d'un groupe de villages.
Clusters are made up of one village or a group of villages which are close to one another, who share a marketplace or a school, for example, and limited to a population of between 500 and 4,000 people. We first did the basic or the baseline survey, for which we took samples, nose and throat samples, and then 6 months later we started the vaccination campaign that ran for a period of 2 months. That was June, July, and August, and then 6 months later we conducted the follow-up study.
Alors, il faut
And
noter que dans
you
chaque,
have to see
concernant les
that
deux enquêtes, dans chaque
for
bloc,
those two
nous avons sélectionné au hasard
tests,
36 ménages.
we selected 36 households at random in each cluster based on the census
Donc, en
list.
fait, il faut noter aussi que les deux enquêtes ont été
You have to
échantillonnées
realize
de
that
manière indépendante.
the two surveys were sampled independently. In each household, the investigators had to first fill a questionnaire, and then they took a nasopharyngeal swab, which was then directly placed in a culture box, and then in a cool box. And the samples were taken to Maradi, where they were kept at minus 80 degrees C before being sent to Kirishi in Kenya for lab analysis.
Alors, pour le
And
calcul de la taille
for the
d'échantillon,
calculation
nous avons
of the size of samples,
une prévalence
we
de base
considered
sur
a
vaccinaux
baseline
à 30%,
VT prevalence of
avec
30%,
une réduction de
with a
50%
50% reduction
en
post-campaign
dans le
in the
bras
full
full
dose arm.
Ça, c'est dans le
So
côté
that's
supériorité.
for the superiority.
Nous avons considéré
And
7,5%
We
du
considered a
bras de
7.5%
entre
non-inferiority
le
margin
bras dose complète
between the full dose
et
arm
le bras
and the fractional dose
fractionné.
arm.
Je vais maintenant vous
And
présenter
I would now like to tell you
une
to show you
description
the results
des
with a
participants à l'étude.
quick description of the participants.
On observe
First
une
of all,
répartition
you
égale
see an even distribution of the age groups in the different arms of the study.
en termes de
In
couverture
terms of
vaccinale du PCV
coverage
vraiment
with
dans
PCV
la première enquête
13, it's the first
du programme élargi de
study.
vaccination.
So,
Nous avons observé
and the PCV3 in 13 in EPI, we had about 40% of the children in each group who had received 3 doses mentioned in their health passport. And about 40% actually had received 3 doses according to the parents' report, but it was not mentioned in their health passport.
conviendrait de noter
So,
à ce niveau que
we have to mention here that
couverture en fait
the
vaccinale les plus jeunes
vaccine coverage of the youngest age group from 1 to 2 years of age moved up to 70%, which is actually higher than planned, because at first we thought that there should be a 50% of vaccine coverage with 30%
vaccinaux
prevalence
pour le calcul de la
in our assumptions for the calculation of the sample size.
Alors ensuite,
And
dans
then,
la deuxième enquête,
in the second survey,
on constate également
we
la
also
répartition
saw
des groupes d'âge dans les
that
différents bras
the distribution of age groups in the different arms of the campaign was almost
la
the same,
couverture vaccinale,
and
cette
the
fois-ci, est
vaccine
passée,
coverage
à 50%
this time
avec preuve
went
carnée,
up to 50%,
plus élevé que dans
as indicated in the health passport, which is a little
base.
bit higher than in the baseline survey. So
par
now,
rapport à notre campagne avec le PCV.
compared to our PCV10
Donc la couverture
campaign,
vaccinale avec preuve de la carte était de
coverage
75%
with the card it was 70 and 75% in the 70 and 75% respectively in the full dose and fractional dose arms, and 21 and 16% in the full dose and fractional dose by report. The people who report having received the vaccine but without evidence provided by the card. So we come to the main results. As you can see at the beginning, we have had a carriage prevalence of any pneumococcus of 16, 18%, 15, 16, and 18% in the full dose and fractional dose and control arm.
Après la campagne,
After the immunization campaign in the control arm,
une moindre différence
we noted a lesser
entre
difference,
une moindre entre les deux campagnes.
a lesser difference between the two campaign
C'est
rounds.
18,8%.
It remained at 18.8% and
Pour ce qui est de
16.5 respectively.
la dose,
As to the other arms, the fractional dose,
une réduction
we saw a reduction between
similaire dans le
18 to 8%, and similarly in the full arm full dose arm, a reduction of 16 to 5%, a drop from 15 to 5%.
Nous avons mené les différentes comparaisons. Donc, dans la
So we made our comparisons
entre full dose
between full dose
campagne de vaccination
and
de masse, donc
without any mass
nous avons observé une
campaign,
plus faible prévalence
the control arm, and we noted a lower prevalence of carriage of pneumococcus in the full dose arm rather than the control.
des campagnes avec dose complète par rapport
And it shows the superiority of a campaign with the full dose compared with no vaccination campaign. And when we compare the full dose and the fractional dose, the lower limit of the confidence interval of the risk difference, risk ratio, 5.10%, is higher than the margin of non-inferiority, which is at minus 5.7%, which allows us to demonstrate the non-inferiority of a campaign with fractional dose compared with a full dose campaign.
Ces campagnes
And finally, these mass campaigns worked very well. We demonstrated the non-inferiority of a vaccination campaign with a fractional dose versus the full dose. Such strategies might be useful to speed up the achievement of herd immunity in a context where you have a high risk of pneumococcus diseases or low vaccination coverage, also in tough humanitarian crisis situations where there is a high need of vaccines, while the supply of vaccines might be limited by import-related difficulties. And I'd like to end my presentation by thanking all the participants in the study, the individuals and institutions without whom this work would never have been possible. Thank you for your attention.
Okay. We take some questions.
Bonjour. Oui. Moi, c'est Guigui.
Good morning. I am Gigi, head of operations. I have a question for Isaka. In the study you presented, are there any other similar data in the literature in terms of the duration of immunogenicity with a fractional dose, or is that underway, or is there a plan to study this further? You know, how long the protection lasts? Thank you for the question. On immunogenicity data regarding the duration of the protection, currently we don't have finalized data, but we know there are other studies underway in Kenya with Cambridge teams, and they're way ahead in the study of fractional dose, 20% first, and now they're looking into the 40% dose. And maybe in Uganda, similar studies are being carried out, but not on PCV, it's on another vaccine.
Bonjour, Julien Potet.
Good morning. Julien Poté. I work for the Access Campaign. A question about Cox's Bazar. First, a comment. You say it's important to do a test and treat campaign, but do you talk between sections? Because I know there are many OCs present there, like the scabies. There is a huge scabies epidemic, and they try to respond collectively to be more effective. So did you have the same discussion between sections on hepatitis C? And a more technical question, how do you account for the differential between men and women? I'm not familiar with hepatitis C, but is that specific to this context?
For the discussion among OCs, yes. OCB is also doing hepatitis C treatment. There was a difference between protocols before, but now we have also we also have the same protocol. The discussions are ongoing among the health advisors. Also, we are discussing with Claire. She will also discuss with the other medical directors. So this is of our interest. All of us are interested. Also, the medical advisors are aligned. Especially for the prevention campaign, especially because we all have very large volunteer presence in the camp. So it will be important that we all align among ourselves and do the campaign together, if there is any.
Thank you for the question regarding higher prevalence estimates for females, specifically exposure. I have to say for active infection that was not significantly different, but it could be explained by different health-seeking behaviors, seeing the risk factors for exposure, injections mostly, so that could be one explanation. And if I recall correctly, in generalized epidemic settings, that is more often the case. I recall a study done by MSF in Pakistan in a refugee settlement published recently, and I remember female also higher exposed, if I'm not misremembering. Thank you.
Désolé. Concerning this specific issue, do you have any idea of the co-infection, hepatitis B and hepatitis C, on this population?
I'll answer and then I'll pass to you. So we didn't have the opportunity to add hepatitis B to the survey. Could have been an interesting opportunity, but there's some indication of hepatitis B in the camps, and I'll let Farah.
From the program data, the prevalence of hepatitis B was quite low. But strangely, there was a difference between OCB data and our data. So there can be difference between camps because we have different camps as catchment population, something we need to explore and something we want to also look at, especially our pregnant women who are coming for ANC-PNC. Team is supposed to start a very dirty kind of assessment when they're coming and see the data, how is the prevalence, and then we can look at it. We also are trying to do neonatal hepatitis B vaccination in our facility. Unfortunately, it's not allowed in the camp by the government, but something we are doing at least in our facilities, all MSF, but we need to also advocate that this is integrated within the EPI schedule as birth.
Some studies in the literature from the Bangladesh Department of Liver Disease, and they had some seroprevalence studies, not necessarily fully representative, but hepatitis C at the time in 2019 was already quite high, but B was low. There were some prevalence, but lower.
Oui, bonjour. Merci pour
Good morning, and thank you for your great contributions. This is just a comment. I am the CERMES General Director in Niger. In Niger, CERMES is a laboratory, a national reference laboratory for influenza. And the idea is to see among all those who can contribute, how we could use the CERMES to have a better technical plateau to contribute to the analysis. We have one partner, Kenya, but we'd like to connect with other partners and ensure technological transfer for this particular vaccine and also for all the vaccines in general, because there are efficacy issues in Niger, issues on the efficacy of vaccines. Good luck to all.
Merci. Moi, c'est Romeric Nzombo de l'Institut Pasteur de Bangui.
Thank you, Romeric from Pasteur Institute in Bangui. Question to Isaka. Did you think of evaluating post-immunization adverse events in both groups? Yes, we did. We looked into undesirable side effects passively until 7 days. We followed up on undesirable side effects that are directly related to the site of injection, to the vaccination, and up to 28 days for severe adverse side effects. So for all three arms, we had 80 severe side effects, but that was related to the period of time we had cases of malnutrition, severe malnutrition, who were hospitalized. And so being hospitalized was already a severe adverse event.
Pardon, j'ai peut-être juste, je ne sais pas si j'ai bien compris la question, mais il y avait une question sur le...
I don't know if I got the question right, the question about technological transfer and the local manufacturing of vaccine, local production of vaccines. Well, you should know that since the end of the COVID pandemic, there were many projects pushed by African leaders to bring back to Africa technologies for making vaccines. Many projects are underway in the Pasteur Institute in Dakar, in South Africa, and in Rwanda, a biotech factory. Those projects are sort of a mix between the fix-finish, the last step in the production of vaccines, in collaboration with a South African company to produce, among others, the PCV vaccine. And there are new technologies with messenger RNA or multi-platform projects like at the Pasteur Institute in Dakar, but those are in the very early phase. But soon, in a few years, we'll see new vaccines that will be partly produced in African countries, and that will be a great plus. Today, less than 1% of the vaccines used in Africa are manufactured on the African continent.
One question about the mortality in the hepatitis C. Sorry, thank you for the presentation. I'm Abdul Wahab, Nigeria Medco. One question about the hepatitis C presentation. I was trying to see the mortality. Do you have any idea about the mortality related to the hepatitis C? Thank you.
Actually, we did not look at mortality in the survey, but in our IPD, of course. But the mortality is not super high. Also, there is a lot of end-stage liver disease who don't really stay in the hospital at the end because their cultural practices like that they want to leave and go home. In that sense, it will not be also maybe accounted in the hospital-based mortality. So this is something we can look at in the community for sure.
Jean-François Tarassion, encore une question sur l'hépatite C.
Jean-François, another question about hepatitis C. There are prognostic factors like the genotype, co-infection with HIV, and the severity of the fibrosis. In your initiation strategy for treatment, do you consider such factors? Do you take them into account?
Donc Suna du département médical.
Suna, medical department in charge of HIV, hepatitis, and clinical leader for chronic diseases.
On appréhendait vraiment d'avoir beaucoup de cas.
Well, we were afraid of having many cases, so we adopted a public health approach
de laboratoire minimum
with minimum laboratory examinations. We didn't do an APRI score to determine whether the patients were positive or not, because we decided if we want to ramp up and scale up, we have to minimize laboratory analysis. So we gave 12 weeks of SODAC to everyone except the patients with clinically visible liver decompensation, such as jaundice, ascites, and the others received 12 weeks. There was no genotyping, no assessment of the fibrosis. We treated more than 4,000 patients since 2020, and we have 14% of cure rate, which is a good cure rate. We decided that those for which the treatment fails, we would do the APRI score, possibly a genotype as well, to better target the second line of treatment. I hope it answers your question. But by and large, in OPD, those are not complicated cases. It's totally different in IPD as opposed to OPD, where we do see many patients with advanced cirrhosis. And even if we treat them for hepatitis C, they come back with a refractory cirrhosis, and then it's often too late. We cannot offer them much, once they have an advanced cirrhosis that is refractory to treatment.
Moi, j'ai une question aussi. Alors, vas-y, s'il y a d'autres personnes, mais c'est toujours sur l'hépatite C.
Another question on hepatitis C.
Bon, j'espère que le nombre de patients qui.
After what Suna said, I hope the number of patients who will be treated will be as high as possible. My question.
En parallèle de traiter pour diminuer le réservoir, je veux dire.
In parallel to treat to reduce the reservoir, what actions can you take in the health centers? We're not alone, but how do people get contaminated? I don't know whether you were able to document this, but it's pretty scary. And practices in health centers, if it's a possible source. And then, do you have drug users among that population? And what do you do in terms of risk mitigation, risk reduction, if it's one way they do get contaminated, to avoid possible new infections?
We asked about intravenous drug use, and there was very few, which is most likely also underreported, so we don't have that figure from the survey. And there's a question here online that matches. It's raising question about awareness on uncontrolled injections in the camp, but I'm passing to you, Farah.
For sure, I think, Mathilde, it's quite important, but there are not many injectable drug users in the camp. But we cannot forget that these population have not had proper health care even before they have arrived in Bangladesh. They have been deprived of a lot of things, including proper health system and healthcare, forever marginalized, forever stigmatized. So in a way, probably they came already with the hepatitis C that was there from beginning. And of course, if you don't have proper healthcare, you go to informal system. And in a way, we speculate that this might be still ongoing. And this is something we really want to focus on, especially when we design our community-based interventions. I think we're running out of time. Thank you so much for all of your interest. Thank you. Do you want to say something?
Thank you.